estimation of LV systolic function is essential in all cardiac diseases, and ejection fraction is still the most commonly used parameter because it has been proved to be a prognostic parameter in numerous studies. However, there are many limitations, like it is an indirect estimate, then it is influenced by loading conditions, then there is a lot of observer and intra-observer variability, and it is not sensitive enough to detect subtle changes. Global longitudinal strain provides more detailed information about global and segmental systolic function, and we can also detect the subclinical dysfunction. But the main limitation of GLS, however, is that besides contractility, it also depends on loading conditions and LV geometry. This is a patient of severe aortic stenosis. The LV function, the ejection fraction looks normal. But look at the GLS. The GLS is significantly impaired. Now, it is very difficult to determine that whether this impaired GLS is due to increased afterload or due to impaired contractility. Myocardial work is a novel echocardiographic method which can reduce the afterload dependence limitation of GLS by incorporating the afterload into the analysis. Now, in this patient of aortic stenosis, if along with impaired GLS, the myocardial work is increased, then this indicates increased afterload. And if myocardial work is decreased, then it indicates impaired contractility. Myocardial work is not a new concept. The original experimental study was published in 1979. They evaluated the myocardial work by pressure-volume relationship measured invasively. But as it is an invasive method, it can't be used in routine practice. Russell in 2012 introduced a non-invasive method to measure myocardial work. Work is a product of LV pressure and stroke volume. Blood pressure can be used as a non-invasive surrogate for LV pressure in absence of aortic stenosis. And global longitudinal strain is a measure closely related to stroke volume, so it can be used in place of stroke volume. Non-invasive myocardial work is derived from measurement of LV systolic pressure via brachial cuff BP and measurement of strain. The profile of estimated LV pressure curve is calculated using an empiric reference pressure curve that is adjusted according to the duration of isovolumic phases and ejection phases determined by echocardiography. And myocardial work is measured from the strain loop, or in short the PSL areas that are constructed from LV pressure and GLS. The strain is on x-axis and the pressure is on y-axis. Now these are the various components of myocardial work which are measured. Global work index is the total work performed by the left ventricle during isovolumic phases and mechanical systole. It is reflected by the area within this PSL. Global constructive work is the work performed by the left ventricle during systole that is productive, which includes both the shortening of the muscle during systole and lengthening during isovolumic relaxation phase. Now, some segments, they go in opposite direction in disease states. So, the work done by these segments is included in wasted work. Global work efficiency is the ratio of constructive work and wasted work plus the constructive work. Global work efficiency is expressed as percentage as it is a fraction. Unit of all other myocardial work component is millimeter of mercury percentage. Now, how to measure the myocardial work? Very simple. Just mark the mitral and aortic wall opening and closure times with the help of Doppler. Then the points may be readjusted in the apical three-chamber view if required. Then measure the longitudinal strain as usual and enter the systolic and diastolic BP. And the machine automatically provides bull's eye of the global work index and global work efficiency of LV with all 17 segments. Now here, this is the bull's eye of global myocardial work, Here the red indicates area of high work, blue indicates area of negative work, and green and yellow are in between. Then this is bullseye of myocardial work efficiency. Here color coding is different. The green indicates higher level of efficiency, red indicates lower level of efficiency, and yellow is in between. Then on the same screen, the values of all myocardial work components and bars indicating the relationship between constructive and wasted work are displayed. Then by choosing a specific segment, we can also compare the global and segmental PSL curves at the same time. Now these are the normal reference values recommended by EACVI NOR study. Here we can see that the normal values of all the components are high in female except the global wasted work. Global wasted work is higher in males. Now coming to the clinical applications. Myocardial work was first described in and validated in patients undergoing CRT for cardiac dyssynchrony. In a normal heart, all the 17 segments contract at the same time and produce a very little wasted work. In presence of LV dyssynchrony due to left bundle branch block, the septal segment moves in opposite direction compared to the lateral, producing a lot of wasted work. One of the major issues in dyssynchrony is to predict that which patient will benefit from CRT. A low myocardial efficiency before CRT is independently associated with better long-term outcome in heart failure patients. For example, here in this representative patient, the efficiency was only 62% and it improved to 84% after CRT. Patients with baseline efficiency of less than 75% showed better survival rates than patients with efficiency less than 75%. This is another study where septal wasted work was used to identify the patients which will respond to CRT. Now here is a CRT responder patient. Note the substantial amount of wasted work in the septal segments before CRT and marked drop in these segments with CRT. Now this is a CRT non-responder patient. The amount of wasted work in the septum was only in moderate range. So the drop was not as marked as with the responder. Myocardial work is also helpful in assessment of response to CRT. In this study, the work difference between the septal and lateral wall combined with the viability detected by a cardiac MRI were the parameters to detect the CRT responders. Here we can see that before CRT, there was a great difference between the work done by the septum and lateral wall. But after the CRT, actually the septum surpassed the lateral wall. In patients with heart failure with reduced ejection fraction, global work index provides incremental prognostic value over ejection fraction and GLS regarding the risk of all-cause death and hospitalization. Patients with global work index of less than 750 were associated with higher risk of all-cause death and hospitalization than patients with global work index of more than 750. In heart failure with preserved ejection fraction, the exertional increase in constructive work after treatment with spinal lockdown was able to predict increase in exercise capacity. Here, before the therapy, there was no significant increase in the constructive work after exercise, but after spinal lockdown therapy, there was significant increase in the constructive work after exercise, and this was associated with improved exercise capacity. In hypertrophic cardiomyopathy, all the components of myocardial work are significantly reduced. Only the wasted work was found to be higher. In non-ST elevation MI patients, presence of a reduced segment work can aid in the identification of acute coronary syndrome. If work index of 1700 was taken as cutoff, 8 of the segments had impaired systolic function in this patient, and the coronary angiogram revealed a occluded right coronary artery. In ST elevation MI patients treated with primary PCI and medical therapy, the regional value of myocardial work index in culprit vessel territory measured before discharge is independently associated with early LV remodeling. Myocardial work has also been evaluated in valvular heart disease with encouraging results. In aortic stenosis, systolic BP cannot be used as a surrogate of LV pressure. So Renuka Jain in her study added the mean aortic gradient to the blood pressure in aortic stenosis patients to estimate the myocardial work. Now, GLS was significantly impaired, but the myocardial work was high. And after the tower, the GLS improved and the myocardial work decreased. So, the increase in the impaired GLS in this patient was due to increased afterload rather than due to impaired contractility. Now, what limitations in future? Myocardial work is derived from strain analysis, so it bears the same limitations like it requires a good image quality, adequate frame rate, and strain tracking should be accurate. Then myocardial work software is currently available only with a single vendor. Then besides afterload, myocardial work also depends on preload. And afterload also besides blood pressure depends on many other factors like arterial stiffness, vascular resistance, reflection waves, and wall stress, which is dependent on LV pressure, wall thickness, LV curvature and radius. But presently we are taking into account only the LV pressure for measurement of myocardial work. We should take all these factors into consideration. To incorporate the wall stress into the measurement of myocardial work, the recently proposed stress strain loop areas integrates the information on wall thickness, radius of curvature and LV pressure to estimate the wall stress. This may be feasible in future by incorporating the method into 3D echocardiographic software. So the take home message is myocardial work is an advanced analysis of LV function by including blood pressure and afterload. Myocardial work is more sensitive than GLS and ejection fraction as it overcomes the load dependent limitations. Clinical applications can be applied across a variety of diseases. Although the prognostic implication and use in clinical practice requires more research, there is much promise in the utility of myocardial work for advanced assessment of cardiac function. Thank you very much.